Welcome back to the deep dive. Today, we're tackling something almost everyone bumps into at some point: back pain.
Yeah, and our sources are clear. The vast majority of times, maybe 80, 90%,
hmm
it's musculoskeletal, benign. It just gets better on its own. But, and this is the kicker, sometimes that simple ache, it's hiding something really serious, potentially even life-threatening. We need a solid plan, a roadmap to tell the difference.
Exactly. That's the mission today. We want to really distill that clinical roadmap, walk you through how experts think step by step. You need to see how quickly the thinking moves from, say, a muscle strain to ruling out genuine emergencies. And we absolutely have to start with the biggest risks, the stability question.
Okay, let's unpack that. First things first, the immediate threats. Anyone working in healthcare knows this. The ABCDE assessment kicks in right away.
Airway, breathing.
Circulation, disability, exposure,
Yeah.
standard stuff. If the patient's unstable, actively crashing, forget diagnosis for a second, just stabilize. That's IVs, monitors, hook up heart rate, BP, oxygen levels, maybe give some oxygen. And this stabilization moment, it's critical. Time is everything. And based on what we've reviewed, there are three big, scary causes of instability linked to back pain you have to jump on immediately. First one, sepsis or a really bad infection. Could be ascites, that's infection of the disc itself, or osteomyelitis, bone infection, maybe even an abscess. Patient looks sick, maybe low blood pressure. You hit it with IV fluids, draw cultures fast, get an MRI stat, and start broad-spectrum antibiotics. No messing around.
Okay, sepsis. Got it. What's number two?
Number two is a visceral source, basically an organ problem causing referred pain. Think like a bowel perforation leading to peritonitis. Again, they might have low blood pressure, but the key is this severe abdominal pain that just radiates straight to the back. Treatment, similar fluids, antibiotics, but you absolutely need a surgical consult, like right now. You've got a leak inside.
Makes sense. Fluids, antibiotics, surgeon. And the third one you said was dramatic.
Oh, yeah. The third is vascular. Something like a ruptured aortic aneurysm. Patient's hypotensive, sure, but the description is unforgettable. Sudden, severe back pain, and they might actually use the words ripping or tearing.
Wow.
Oh, yeah. If you hear that, it's immediate fluids, a CT angiogram, that's a special CT to see blood vessels, and an emergency call to vascular surgery. Missing this is, well, it's catastrophic.
Okay, that really sets the scene for the absolute emergencies. Thankfully, like you said, that's not most cases. So let's pivot. The patient is stable. What's next?
Right, stable patient. Now we can take a breath and do a proper focused history and physical exam. We're feeling along the spine, the muscles nearby, checking the abdomen, pelvis for any tenderness.
But the real diagnostic horsepower here, it comes from screening for specific red flags, right?
Yeah.
These are the signs that tell you, hold on, this isn't just a simple strain. These flags mean you need more investigation, probably starting with a spinal x-ray.
Exactly. These red flags are crucial. Age is a big one. Pain starting before you're 20 or after you're 55. That's a flag. Then you look for major nerve issues. Severe weakness or numbness, especially if it's getting worse quickly. Or new problems controlling urine or bowels, that's huge. And beyond symptoms, their history matters too. History of cancer, red flag. Previous spine surgery, red flag. Significant trauma recently, also a flag. Or things that might weaken the system, like long-term steroid use or history of HIV. These change the game completely.
And these flags point us towards some really serious conditions that need urgent attention, even if maybe not immediate surgery. Let's dive into maybe the scariest one first, cauda equina syndrome.
Right. The cauda equina, it literally means horse's tail in Latin. It's that bundle of nerves hanging down at the end of the spinal cord. Super important, sends signals to your legs, your bladder, your bowels. If that gets compressed, often by a huge disc herniation or a tumor, it's a neurological emergency.
What does that look like symptom-wise?
Progressive weakness and numbness in the legs, loss of bladder or bowel control. Those are key. But the absolute classic, the thing you have to check for on exam, is saddle anesthesia.
Saddle anesthesia. Explain that.
Imagine sitting on a horse saddle, the parts of your body touching the saddle buttocks, perineum, inner thighs, if there's numbness specifically in that area. That's saddle anesthesia. Combine that with finding decreased anal sphincter tone on exam. Well, that's almost certainly cauda equina. You need an MRI right away to confirm the compression, usually down in the L1 to L5 region.
That's a fantastic example of how one specific finding totally changes the direction. Okay, let's talk about another red flag situation. Infection in a stable patient. Maybe they have a history of IV drug use, or a recent surgery, or they're immunosuppressed from meds like steroids.
Yeah, and what's really interesting here, a key point from the sources, is that the first imaging test, usually an X-ray, it might look totally normal.
Even if there is an infection like ascites or osteomyelitis.
Exactly. X-rays are great for bone, but early infections might just be in the soft tissues or the bone marrow, and the X-ray won't pick that up yet.
So the takeaway is, even with a clean X-ray, if you have those risk factors, immunosuppression, recent procedure, maybe a fever you can't explain, you still have to suspect infection.
Absolutely. The clinical picture, those risk factors, they trump a negative X-ray in this case.
Yeah.
You should still be thinking about getting an MRI, which is much better for seeing infection, and definitely getting blood cultures.
Okay. Third major red flag area, malignancy, so cancer or metastatic disease in the spine.
Right. You're looking for someone with a known history of cancer presenting with new back pain. Or maybe they don't have a known cancer, but they have those systemic symptoms, losing weight without trying, drenching night sweats.
An X-ray might show lesions, like holes in the bone, but you need confirmation.
Usually, yes. A biopsy is often required to be certain. And there's a pattern here the sources really highlight. The three most common cancers that like to spread to the spine are lung, prostate, and breast. Worth remembering that triad.
Lung, prostate, breast. Got it. All right, let's keep moving through these red flag diagnoses in stable patients, shifting more towards structural problems now. What about spinal fractures?
Often you see these, especially compression fractures, in older patients. Maybe they have osteoporosis, maybe they've been on steroids a long time, or maybe there was a clear trauma, like a fall. The pain is usually very specific to one spot, and it really hurts when they bend forward. And the imaging choice is important here. You just want to confirm, is there a fracture? A CT scan is generally better for looking at bone detail. But if you're worried the fracture might be pushing on nerves or causing the spinal canal to narrow stenosis, then you need an MRI to see those soft tissues in the nerves themselves.
Good distinction. Okay, next up, a term lots of people hear, spinal stenosis. Not narrowing of a spinal canal, right?
Exactly, often from just wear and tear over time. Causes pain, numbness, weakness often in the back, buttocks, legs. But the real giveaway clue, the key differentiator, is position. The pain from stenosis is almost always worse with extension. Things standing tall, walking for a while, arching your back. That position naturally makes the spinal canal a bit smaller, but the pain gets better with flexion, bending forward, sitting down,
Or the classic example.
leaning on a shopping cart. That slight forward bend opens up the canal just enough to relieve the pressure. It's a very telling sign.
That shopping cart visual really sticks. Okay, so contrast that with a disc herniation.
Sort of the opposite in terms of position sometimes. With a herniated disc, the pain often increases with spinal flexion, like bending forward to lift something heavy. And you might see signs of radiculopathy, nerve root irritation, meaning specific weakness in certain muscles, what we call myotomal weakness, or numbness in a very defined pattern down the leg, dermatomal sensory loss. And the straight leg raise test, lifting the affected leg while lying down, will often reproduce that sharp shooting pain down the leg. MRI confirms it, shows the disc bulge or tear pushing on the nerve.
Okay, great. We've covered the immediate life threats, the stable patient with serious red flags. Now let's zoom back out. What about the stable patient with no red flags? This is where most people fall, right?
Exactly. This is the most common scenario.
Yeah.
And if there are no red flags, the first thing we usually think about is simple muscle strain or sprain. This is what we call a clinical diagnosis. Basically, you rule out the bad stuff. There's usually a story, like recent heavy lifting or awkward movement, maybe in athletes like gymnasts or dancers. Pain gets worse with movement, better with rest, and crucially, their neurological exam is completely normal.
But it's not always just a muscle strain, even without red flags. Sometimes an X-ray is still needed. Tell us about mechanical back pain involving the structures themselves, like spondylosis, spondylolisthesis, big words.
Yeah, they sound complicated, but basically, spondylosis is just arthritis or wear and tear in the spine. Spondylosis is a small stress fracture in part of a vertebra. And spondylosis is when one vertebra actually slips forward on the one below it.
Okay, and how does that present?
Pain usually gets worse with moving around, but again, the nerve exam should be normal. Unless that slippage, the spondylolisthesis, is bad enough that it starts pinching a nerve. The X-ray is key here. It can show that slippage, sometimes you can even feel a little step off on the person's back, or signs of arthritis like narrow disc spaces.
Yeah.
Now, besides mechanical issues, we also have to think about inflammatory causes. Things like ankylosing spondylitis AS or reactive arthritis, these aren't just wear and tear, they're systemic diseases.
So the symptoms are different.
Definitely. It's not just back pain. Patients often report terrible stiffness, especially in the morning, that actually gets better with activity. They might feel fatigued, have swollen joints elsewhere. Sometimes you see the classic triad of reactive arthritis, arthritis, conjunctivitis, eye inflammation, and urethritis.
You mentioned x-rays can look pretty distinct here, too.
In advanced AS, yes. You can see these bony growths called syndesmophytes bridging across the vertebrae. It can eventually fuse the spine into what looks like a stalk of bamboo on the X-ray, the classic bamboo spine. But diagnosis isn't just imaging. Because it's inflammatory, maybe autoimmune, you check blood markers like ESR and CRP.
And you brought up something specific in the sources, the HLA-B27 antigen. Why test for a gene marker for back pain?
Yeah, that's a fantastic point because it highlights the systemic link. HLA-B27 is a genetic marker strongly associated with these types of inflammatory arthritis, like AS. Finding it doesn't automatically mean they have AS, but it massively increases suspicion. It tells you this isn't just a bad back. It's likely part of a bigger, genetically influenced inflammatory process affecting the whole body. And that totally changes treatment. You're thinking less about physio and more about medications that target the immune system.
That's a huge distinction. Okay, finally, let's wrap up with referred pain. When the back exam is normal, x-rays are clear, but the pain persists. It might not be the back at all.
Precisely. Could be coming from GI or GU sources, gastrointestinal or genitourinary. Look for other clues: belly pain, flank pain, nausea, vomiting, pain with urination, blood in the urine. A CT scan of the abdomen and pelvis can pick up things like pancreatitis, kidney stones, even certain cancers like uterine cancer presenting as back pain.
Or it could even be vascular again, even if stable now.
Right, referred vascular pain. Maybe deep abdominal pain radiating to the back. Particularly consider this in someone with risk factors: smoking, high blood pressure, high cholesterol. Again, a CT scan is needed to look for things like an aortic dissection that hasn't ruptured yet, but is still causing pain. So if you step back and look at the whole journey, that seemingly simple complaint, "my back hurts," actually forces this really structured diagnostic process. You go from immediate stabilization to that vital red flag screen looking for cauda, equina, or cancer, all the way down to figuring out if it's mechanical, inflammatory, infectious, or referred pain from an organ. It has to be systematic to catch the dangerous mimics.
So what's the big takeaway here? It really sounds like the complexity isn't just how much it hurts, but the specifics of the symptoms. We've heard how tiny details like just sitting make it better or worse. Is there numbness in that specific saddle area? Those are the clues that can instantly flip the diagnosis from take some ibuprofen to get an MRI right now.
Exactly. And maybe a final thought to leave folks with, circling back to those inflammatory causes. It's a powerful reminder that medicine isn't always just about what you see on an X-ray or MRI. For that subset of people with chronic back pain and stiffness, the real answer might not be found just by examining their spine, but by looking deeper into their genetics. Finding that HLA-B27 antigen connects their physical pain to a hidden chronic systemic immune condition, it really changes the whole perspective, something for you to mull over.